Good afternoon and welcome to our webinar, Health System Resilience and COVID-19, Lessons and Strategies for Building Back Better. COVID-19 is a massive shock to health systems, economies and societies, and we all know it won't be the last one. The next crisis is just around the corner, whether it is another virus, a debt crisis, a migration crisis, or whatever will come. So it's really very important to get ready for the next one and to strengthen our health systems and make them more resilient for whatever may come. And we have analyzed over the last 18 months shortcomings and deficiencies of health systems laid bare by the pandemic. And we've also looked at all the responses countries have taken to address these issues. We have a long list of issues covering all the health systems function, from governance, resources, finance, service provision, and there are patterns and there are lessons to be drawn from this. And today we will discuss 20 key strategies that help policymakers to make decisions for building back better. So we will hear a lot about the crucial role of governance, how to deal with finance, how to strengthen health workers, and the transformation of care. And the best, all this talk today is based on evidence, because we just launched a new volume entitled Health System Resilience During COVID-19, Lessons for Building Back Better. And this volume is a joint effort. It's a joint publication between WHO Regional Office for Europe, the European Commission, and the Observatory. And today we are in the lucky position that we have 4 of the editors with us talking about the volumes and talking about some of the implications of the volume. And first of all, I would like to introduce our keynote speaker, Erin Webb from Technical University Berlin in Germany. As spotlight speakers, we have Martin McKee, professor at the LSHTM and also research director of the Observatory. And then we have Isabel de la Mata, who's Principal Advisor, Health and Crisis Management at DG Santé, European Commission. And last but not least, Natasha Atsupadi will join us. She's Director, Country Health Policies and System at the WHO Regional Office for Europe. Just a couple of things for the housekeeping. Please use the chat to put in your comments, questions, and whatever. Also have a look at the chat, because there will be links for downloads also for the book. This session will be recorded, and in due course it will be made available on our YouTube channel. And finally, as I say, download, read, and act. Before we start with the keynote, we would like to do a little audience poll. Erika, can you please launch the poll?
Just a little poll just to see where we are at the moment. It's an anonymous poll, so just wanted to know, is your country already drawing lessons for strengthening health systems resilience based on the experiences so far? And that's a simple yes, no question. And then we'd also like to know a little bit more detail. So is your country seriously addressing the following policy options to strengthen health system resilience? So are they strengthening public health, primary care, human resources, making service provision more flexible, investing in monitoring, surveillance and early warning systems, strengthening health system governance, or indeed none of the above? So I'd be really interested to hear your feedback on that, and I'll let you know the results after Erin's overview. Thank you very much.
Thank you so much, Erika. And that is the moment to invite Erin Webb from Technical University Berlin. Please, Erin, the floor is all yours.
My name is Erin Webb, and I'm a research fellow at the Technical University of Berlin, one of the 2 research hubs of the European Observatory. Today, I will present on behalf of my co-authors and editors, who all contributed significantly to the work I will share. I especially want to acknowledge Anna Sagan, the lead author and editor of the study, who is unable to attend today. I would also like to emphasize and thank all of the contributors to the COVID-19 Health System Response Monitor, which forms the basis for the strategies and lessons that we have identified in this study. We have distilled the information into 20 key strategies in the table you see here, and we've defined the concept of resilience as the ability to absorb adapt, and transform to external shocks. The 20 strategies can be grouped into 5 categories that broadly correspond to the core health system functions. Roughly divided, about half of the strategies relate to governance. The other half show how countries have increased or adapted their financial, human, and physical resources to ensure dual delivery of public health and healthcare services to meet COVID and non-COVID needs. This study is a testament to the resourcefulness and ingenuity of the many ways in which health systems have demonstrated resilience during the COVID-19 pandemic. The first 9 strategies listed on the slide here focus on leadership and governance. Governance, or how systems are made and implemented, is a major determinant of whether health systems are resilient in the face of a shock. While I won't go into each of these strategies, we cannot underemphasize the role of governance. One of the reasons why governance is so important is because it enables or activates all of the other health system functions. The governance of financial resources determines how quickly and transparently funding can be made available. The governance of health workforce can affect how quickly contracts can be updated for a more flexible deployment of key healthcare staff. And the governance of service delivery can enable or slow down the implementation of innovations such as digital health. Strong governance also supports effective political leadership of the broader response, and this corresponds to our first strategy on this slide. Governance provides the frame that captures the extent to what is possible for politicians and leaders, and it can therefore provide a defense against particularly bad ones. The governance function also goes beyond the health system through interactions with other sectors, such as social services and education. And it's increasingly conducted across levels, from local to global levels, and this has become important as we have seen in this pandemic. While countries can learn many positive lessons from each other, our study showcases multiple examples of governance problems, starting with gaps in monitoring, surveillance and early warning systems, through inadequate communication and stakeholder participation, to problems with coordinating responses within countries and beyond national borders. At the same time, new approaches to governance, such as international initiatives and the inclusion of broader stakeholder groups, have provided support to the government in the pandemic response. I'd now like to move to health financing. Health financing faced a situation where at the same time, there were increased expenses and reduced income. The need for more funding came from a sudden demand for COVID-19 related services. These services often incurred substantial costs. There were long hospital stays, isolation treatment, and complex care on intensive care units. At the same time, increased expenses came from new tasks. These included testing and treated COVID-19 patients, increased home visits, remote services, as well as stricter hygiene and physical distancing requirements within healthcare settings. While all of these funding needs came in, healthcare providers in many countries faced reduced incomes. Elective admissions were temporarily put on hold, patients avoided seeking care, and taxes and contributions decreased due to financial crisis and unemployment. Out of this situation, adjustments in financing had to be made, and we identified 3 strategies surrounded by the yellow box on the right. First, health systems had to ensure sufficient and stable funds to meet needs. They had to quickly adapt their purchasing, procurement, and payment systems, and these changes had to be made while supporting universal health coverage and reducing barriers to services. Perhaps more than any other area, the initial capacities of the health workforce made a huge difference going into the pandemic. Norway has 4 times as many nurses as Latvia for its population size. And even within countries, there are differences, with rural and deprived areas worse served. The profile of the workforce also matters in terms of the specific skills or scope of practice. In the context of COVID-19, ICU doctors and nurses, respiratory therapists, and public health workers were especially in demand. But health systems must be resilient to various types of shocks beyond COVID-19, and this affects the health workforce enormously. During the COVID-19 pandemic, nearly all countries had to scale up their health workforce to meet increased demand, including for things such as vaccination programs, while managing infection among health workers. At the same time, routine services had to be maintained. The first strategy we identified is all the strategies that countries used to manage the expansion of capacity of the existing health workforce, bringing additional workers in or redeploying workers to areas with the greatest need. We also observed flexible approaches, such as reskilling and repurposing to meet specific needs of the pandemic. This included health workers taking on new tasks, task shifting, reskilling to work in different roles or with digital technologies, and introducing or expanding the use of multidisciplinary teams. These first two strategies within health workforce placed extreme demands, and new workers and skills required training and demanded a lot from the existing health workers. So the third strategy emphasizes the need to support our health workers, especially to prevent burnout and workers from leaving the profession. Protecting physical health, mental health, and well-being, and offering financial compensation, acknowledgement, and other practical support is more important than ever. Public health and primary healthcare are closely linked, but not consistently defined across Europe. Yet they play a key role in both reducing transmission and maintaining routine public health services. The balance of promoting non-pharmaceutical interventions, carrying out find, test, trace, isolate, and support activities, and launching a COVID-19 vaccination program presented a huge challenge for public health. Simultaneously, routine services such as screening, checkups, and other vaccinations had to continue. And not only that, primary healthcare providers often supported treatment for mild COVID-19 cases. The strategies identified here emphasize the difficulty of balancing these activities and need for continued support and investments. Now, I know I'm going through the strategies and groups very quickly, so before introducing the last group, I would like to pause. And with this pause, we can remind ourselves that all health systems functions support service delivery and the ultimate health system goal to improve health. When we think of the groupings presented so far, they all ultimately target improving health. More flexible financing mechanism enable access to services. A well-trained and supported workforce provides the right care for patients at the right time. And public health and primary health care help protect the health system from becoming overrun. And behind all of this, as the lever and foundation to everything, is governance. Each of these groups and related strategies overlap and cannot be considered in isolation. With this context and framing in mind, we can think about some of the biggest challenges that the health system function of service delivery faced during the COVID-19 shock. One was the need to cope with sudden surges in demand. At various points during the pandemic waves, the demand for COVID-19 services overwhelmed hospitals and other care providers. While most countries took strong action at the beginning by postponing or canceling non-urgent care, it soon became clear that this response couldn't sustain as long as the pandemic. This introduces a second challenge, often framed using the term dual delivery of care. The question here is, how could healthcare providers treat COVID-19 patients while still maintaining other services? With these two challenges in mind, we identified two strategies for resilience of service delivery. The first is scaling up, repurposing, and redistributing capacity. Countries increased bed capacity, especially in the ICU setting, and used spaces in innovative ways. And the second, final strategy, highlights the ways healthcare providers adapted or transformed service delivery through flexible patient care pathways, innovative uses of remote services, and more. While there's much that we can look back on, we can also look forward to what's next. COVID-19 is only one shock, and future shocks might look different. The pandemic has reminded us of the structural and chronic vulnerabilities of the health system and reinforced the need for targeted investments in certain areas. These include strengthening public health, primary health care, and human resources, making service provision more flexible, including through innovations such as digital health and remote consultations, well-functioning monitoring, surveillance, and early warning systems, and health system governance, which goes behind everything. The figure on the right side of the slide from the Monti report also reinforces these messages and centering around One Health. And even though right now the gaps seem clear, there is a narrow political window of opportunity to implement reforms that would contribute to long-term health system resilience, and an ongoing prioritization of health is needed to build back better. Coming on 2 years with COVID-19 and not knowing at the beginning of the study that it would be still relevant when it came out for publication, we can see that countries have followed many paths, but countries that have performed better share many of the same features. They have decisive leaders who understand science and are ready to act on the evidence. They have access to high-quality intelligence on the trajectory of the pandemic. They have secured public trust. They can draw on strong public health institutions and well-resourced health systems, and their populations are adequately protected by social safety nets. The new study, Health Systems Resilience During COVID-19, captures many of these features into the 20 strategies I presented today, and also introduces some initial ideas of how to assess each strategy. Thank you for the attention, and I encourage you to check out the study.
Thank you so much for this excellent and concise overview on this massive volume with its 20 strategies. And also thank you so much for emphasizing the role of governance as an enabler. And usually, governance is very often invisible, but now during the COVID-19, it was like open heart surgery, and everybody had an opportunity to see, whether leaders were really leading, whether they were failing, whether they managed to decentralize and re-centralize at the right minutes and govern across all the different departments of the government, and also whether they effectively reached out to civil society and professional association. Thank you so much. We'll come back to you in the panel discussion. And now I would like to ask my colleague Erika. Erika, what are the results of the poll?
Well, the good news is that the majority of countries are already drawing lessons for strengthening health system resilience based on the experiences so far. And that the main areas that are being prioritised so far appear to be strengthening public health, primary care and human resources, but also investing in monitoring, surveillance and early warning systems. Slightly worrying, about a fifth of respondents have said that none of the above are being implemented. That doesn't mean, of course, nothing is being done. It might just be that it wasn't covered in under the categories given there, but certainly a lot of scope for learning. So thank you very much for that, everyone.
Thanks a lot, Erika. And we can only hope that those countries which haven't started yet will have a look into the volume. Give the floor to Martin McKee, our first spotlight speaker. Martin, the floor is all yours.
Right. Thank you very much for asking me to participate in this session, Matthias. So in the few minutes available, I just want to reflect briefly on what needs to be done at the international level to support the resilience of health systems. And it's something that we've been thinking a lot about in the Pan-European Commission on Health and Sustainable Development. And I do hope that everybody has had an opportunity to have a look at our report, which is on the WHO Euro website and which informed the work of this volume on resilience. So, as with any problem, the first thing to do is to make a diagnosis. We know that health systems have been struggling during the pandemic, but why was this? Well, you might reasonably say that the answer was obvious. In many countries, we allowed our health systems to be neglected, especially in the years following the financial crisis. We sat back as they were sacrificed in the altar of austerity, a policy that in many countries took the characteristics of almost like a religion. To succeed, politicians competed to declare their faith in what we call fiscal prudence. And as a consequence, many countries were unprepared for the pandemic. Their health systems had too few health workers, and they lacked the capacity to expand rapidly to meet the increasing needs of their populations, as Erin has described. Now, it wasn't the case everywhere. There were countries that had adequate capacity, but of course, even they struggled. But they were in a better position than those that had perhaps 1/5 of the number of intensive care unit beds or many fewer doctors and nurses. But it wasn't just that the health systems were under-resourced. In some countries, the load placed upon them was really enormous because for decades, health systems have been picking up the pieces of failures in other sectors. Deregulation of the labour market, the declining power of trade unions have been pushing tens of thousands of people into precarious employment, people who don't know from one week to the next whether they will have a job or an income. And in some cases, they can't even be confident that they will have food or shelter over their heads. So you don't need to know much about the social determinants of health to realize that this will make them vulnerable to disease. And it was hardly any surprise that the areas worst affected by the pandemic were also the poorest. But what can we do about this? Well, the first thing to do is to invest in healthier populations so that when crises strike, communities, families, and individuals will be better able to withstand the challenges. Now, most of what is needed will have to be done at the local or the national level, but at an international level, we can help by supporting the creation of information systems that capture inequality in comparable ways across countries, measuring poverty, ethnicity, and migration status and other crucial variables in ways that allow us to discover which countries are doing well at protecting their populations, all of their populations, and which are not. And if we can do this, then those who are struggling can learn from those who are succeeding. But then, of course, we need to invest in and strengthen our health systems. Now, most of the necessary responses will be the responsibility of local and national governments and other actors within countries. But the challenge at an international level is for us to make it easier for governments to make the right choices. Well, in our report, we set out a number of things that could be done to help them make these choices. We've long known that better health can promote economic growth. Healthier people are more productive. They spend more time being active in the labour market, either because they don't retire early or they work more hours each week, and they invest in their own development. So in this way, health is just like education or transport or digital infrastructure. It is an investment, but our accounting systems don't see it that way. They regard it as a cost. So we need to look at things like international accounting standards, if we're going to put this right. Now, one of the reasons why governments invest in particular sectors is because they know that they will suffer at the hands of credit rating agencies if they fail to invest. Yet one thing the pandemic has taught us is that if they don't invest in preparedness, then they will take a massive economic hit. So we need to look again at how we assess the risks that governments face. Rather than punishing them for spending on health, we should be asking whether a failure to support their health systems is actually reckless in the face of unknown future threats. Now, I'm sure that many health ministers dream of being finance ministers. Think of the power over the purse strings. But let's face it, it's not as easy as it seems. It's not, if it's not the credit rating agencies that are knocking on your door, then it's the international financial institutions like the IMF. And when they come to town to do their Article 4 consultations, you know that they're going to ask difficult questions. So we need to make sure that these questions also address resilience, that resilience is factored into their assessment. Once again, investment in preparedness is a virtue, not a sin. And finally, we need to look at global governance. Now, we proposed the creation of a global health and finance board under the auspices of the G20. And we drew for our inspiration on the Financial Stability Board, which was created by the G20 in the aftermath of the global financial crisis. You might have asked, why wasn't there a crisis of liquidity at the beginning of the pandemic? And if you haven't asked, maybe you should, because we now know that it was the work done by the Financial Stability Board, initially under the leadership of Mario Draghi and Mark Carney, that prevented this from happening. And we're really lucky that it did. Things could have been a lot worse. So our proposal is to create a similar body for health and finance, bringing together those two ministries. And this would, like the FSB, wouldn't just be the G20 countries, but it would have much wider involvement. Now, this would make sure that the money was available when it was needed. But importantly, those finance ministers will do everything possible to make sure that they don't need to spend the money. So then they will prioritize investment in resilience and resilient health systems. And this takes me to my concluding thoughts, the issue of sovereignty. This will require countries accepting that they have to, we're all sharing this planet together. They cannot simply make decisions on their own because the decisions they make affects everybody else. But that's a very complex topic, and maybe we can leave that for another time. Thanks very much.
Thank you so much, Martin, and also for reminding us that actually some of the health systems confronted with COVID-19 were still weakened from the last crisis and the policies adopted after the last crisis. And also, thank you so much for expanding the topic a little bit. First of all, towards the determinants of health and the questions of inequities with which health systems need to deal, but also that you are linking it to the global context of investing in health actually and governing for health. So that's great, and that allows me now to move to the next speaker. Isabel, please join us, and the floor is all yours.
And thank you for allowing me and the European Commission to be here present at this important webinar. It will take years before we will have a full understanding of what has happened with the COVID-19 and the impact that this had. At the beginning, before joining the conference, among the other speakers, we were saying that we hesitated when we put in place the website and the volume to discuss the impact of the COVID and the resilience of the health system, because we didn't know if this was going to take long time to recover or not. And we are 2 years after, still in the middle of this pandemic. We have some examples like the mortality and morbidity that have increased, of course, as an immediate impact of the pandemic across Europe. But for example, the life expectancy that had increased all over the 20th and the 21st century decreased for 1 year, just in 1 year. And this decrease in life expectancy was not seen since the Second World War in some countries. So this is an important impact of the COVID-19. The health system needs to address both the short and the medium-term effects that we don't have a complete understanding at this moment. And here I am also referring to the people that are suffering from the long-term COVID, and those whose health worsened because of the foregone non-COVID care and the mental distress. The cross-border data collection and the data sharing will help us to understand the health impacts. It will be crucial to strengthen the health data collection, the analysis to support more evidence-based health policy making. The European Health Data Space, which is an initiative on the European Health Union, will contribute to promote better exchange and access to the health data. And it will build on a strong system of data governance and high quality and interoperable data leaning on solid infrastructure and technology, and is one of the priorities of the European Commission. The digitalization of the healthcare is happening now. We have seen how the digital health tool has exploded, especially telemedicine has increased. The EU citizens had a remote consultation, and this has reached almost 40% of the consultations in general. We have also seen the implementation of digital platforms and apps for public health, such as contact tracing apps, the COVID-19 digital certificate, and the European Union has played an important role in ensuring this interoperability, and the EU digital COVID certificate is now the global standard that is used by 45 countries. This rapid innovation, of course, needs to be evaluated, and it will be important to start the process now. We will continue investing in digital infrastructure and equipment to enable the health system to capture the full potential of the digital tools. But the digitalization alone cannot build stronger health systems and better preparedness for future public health crises. The pandemic has put the workforce shortages under the spotlight, an issue that existed already before this crisis in 2020. The workforce shortages worsened during the pandemic, and in many regions, the situation became critical. And the situation on the intensive care unit has already been mentioned, but not only there. We need to remember the primary healthcare situation and how some programs should to be stopped, like the vaccination programs for a while where we were at the beginning of this pandemic. In the majority of the EU countries, medical and nursing students were mobilized to support the clinical staff, and retired staff was also reactivated. And some staff was also redeployed from care settings with overcapacities to assist in the COVID care. And here, one of the projects that was quite successful was the training of health professionals on intensive care skills to allow this redeployment. Also, some member states have sent and are still sending medical staff to more severely affected ones with the support of the EU civil protection mechanism. And others also reserve intensive care capacity for patients from other European Union countries. The health workforce has been tested to the limit. The pandemic has taken a large toll on the physical and mental well-being of health workers. The member states have rolled out a number of supportive measures to ease the burden on the health workforce, such as the mental health support services with the 24-hour helplines, a special child care scheme, or temporary salary increase to support the professionals. But still there are worrying signals that the distress caused by poor working conditions is leading to health workers leaving the profession, which is something that we will have to address and that we will have to avoid. As the need of health workforce became more urgent than ever, a mix of policies have been initiated to build a more resilient health workforce. Reskilling, upskilling, improved working conditions are key factors to create a well-equipped workforce that can support future health crises. And this can only be achieved as long as we continue to invest in training and educating our workforce and improving their working conditions. Building effective, accessible, resilient health system was on the Commission's agenda already before the pandemic. But the extent of funding instruments that are now created goes beyond anyone's pre-pandemic imagination. We are also building a European Health Union that will ensure that we are better prepared the next time. We have established the European Health Emergency Preparedness and Response Authority, the HERA, that will complement the work of the European Medicines Agency and the European Centre for Disease Prevention and Control, both in building preparedness before crisis hit and in response capacity during the crisis. The Recovery and Resilience Facility that is helping the member states reform and invest in health. Another example of support is the EU for Health program, a standalone health program of 5.3 billion euros, that is 12 times more than the previous health program. So this program can and will support multi-country projects and studies, as well as procurement to build a stronger health system. We will share now a little bit advertising, further analysis with the publication of the 2021 country health profiles and the accompanying report on health system resilience, what we call the companion report, that will be published next month. This is a joint project with the OECD, the Observatory, and the European Commission. And what is important is that we are all contributing to measure, study, analyze, and try to find a solution to increase the resilience of the health systems in Europe. Thank you very much, Matthias, and thank you very much.
Isabel, thank you so much. Martin was just saying that we really need to work together and we need to come together and exchange. And you just gave us a very long list what the European Commission is actually already doing. It's a cross-border collection of data, European health data space, digitalization, interoperability, investment, EU civil protection mechanism, funding instruments, recovery and resilience facility, the institutional reforms like HDEA, ECDC, EMA, and I probably forgot something. It's so much. And you also mentioned the Europe-wide studies on health system resilience. I think these are very good examples and very good to see that this is going forward. And I hope that all the member states are moving with the European Commission on this one. Thank you so much, Isabel. And now I would like to ask Natasha Atsupadi to join the webinar. Natasha, very good to see you here. We already had a quite lively debate. The floor is all yours.
Thank you very much, Matthias, and good afternoon. And I mean, so much has been covered already by Erin in her fantastic presentation. She really managed to summarize the gist of this publication in a very concise and comprehensive manner. And then Martin, of course, and here we're very grateful as WHO Regional Office for Europe to the support provided by the Observatory, but particularly by Martin in supporting us really to support the independent commission chaired by Mario Monti, which was convened by Hans Kluge more than a year ago already now, in order not only to look back at what went wrong in the pandemic, but very much to look forward at what needs to be done differently. And I think Martin has really outlined the key areas that we are being asked to move into, really being asked to move outside our comfort zone. And it was, of course, very interesting even just to be able to witness the operations of the Commission up close, where we brought together former heads of states, ministers of finance, and people from the health sector, and where it was very clear that a lot has to be done still to engage better and to come up with a common narrative that everybody can really adhere to and understand. And I think this is what the Monti report, as we fondly like to call it, underpinned by the excellent evidence review, has brought together. And then Isabel, I mean, it's just incredible what the pandemic has done to put health very much center and front of the EU's agenda. And of course, this is really great. And we are also very grateful for the support that we are getting from a number of areas within the Commission, not least, for example, DigiNear, amongst others, where we are working in countries in the eastern part of the region, such as the Western Balkans and Eastern Partnership, to try to strengthen the resilience. And one of the things I think that often people tell us is, but, you know, what do you mean by resilience? This is rather a theoretical concept. And I think what I would like to do in the next few minutes is to just very much concretely and practically share what we are seeing as WHO that needs to be strengthened if we really want to make sure that our countries have resilient health systems. And I think one of the things that has been mentioned by all speakers is really the workforce. And when we talk about a resilient workforce, we have to be very careful that this is not interpreted just as, you know, health workers should strengthen their own resilience and that they need to be tough to be able to cope. I mean, health workers have done miracles in remarkable situations over a very protracted period of time. And all the surveys and statistics are showing us actually what a toll this has taken and the attrition that we are facing in the health sector, which is going to really make a dent in our workforce in the months and years to come, because there is absolutely no way we are going to be able to replace this overnight. And one of the things I think that we need to be conscious of over here within the European region also is the extent to which we have become reliant on workers outside the European region to fill and staff our health and long-term care systems. And we can't talk about resilient health systems in Europe unless we really grasp this nettle, which is of course a very difficult one, and find ways in which we can actually grow our health workforce within Europe and also find better ways for ethical and sustainable recruitment and engagement of health workers from other regions through, for example, concepts around circular development and circular migration, addressing really development needs. Of course, as soon as we start talking about increasing the wages for health workers, as needs to be done in a number of countries quite clearly. And yesterday in a meeting that we organized also with the support of the European Observatory, where the publication was launched with member states, we heard how many countries have actually moved to try to improve the working conditions of the health workers. But of course, this then brings us very much to the financing, and we know that health is a labor-intensive sector, and as soon as we start eating into the fiscal space, this brings us full circle round to some of the points which Martin was talking about, and the way in which we really need to engage with the bankers, the financiers, to ensure that we no longer continue putting a lid on the health sector, perhaps a somewhat arbitrary lid on the health sector, and that we allow it to grow and to have the fiscal space that it needs to grow. Second point is about the services themselves. And yesterday I was struck listening to a number of countries who intervened around really building resilient health systems, about the way in which primary healthcare ended up being one of the most resilient factors throughout the pandemic. And that if it weren't for a strong primary healthcare system, many health systems would have collapsed. And in fact, one of the factors that emerged quite clearly is that those countries that did better had a stronger primary healthcare network made up of multidisciplinary teams, closely linked through pathways with the hospital network, but also linked very much to the public health local services too. And I think that this is one of the points that we have tried to address also at the last regional committee, where we put together a document and a resolution, which was very much looking forward about how we can better realize the potential of primary healthcare, recognizing that it was a cornerstone and keystone. Third, we mustn't forget hospitals. Last week, I was in Barcelona addressing the World Hospital Congress, and clearly hospitals are facing their own revolution. They are being asked very much to go outside their walls. Something, for example, that a number of hospitals in the US were not typically used to doing, and found that they had no choice during the pandemic but to engage with the communities, particularly those who are most at risk and most vulnerable, and who were the ones coming through their emergency doors during the pandemic. And fourth, I think we need to take a long look at how digital technologies have contributed, are contributing, and can contribute much better to support the resilience of our health systems. And here the narrative that we are really pursuing and pushing is that we need to align digital technology investment with health system needs, and particularly with health workforce needs and patient needs. So let me stop here. There's so much more that we can talk about, including ensuring robust and resilient supply chains. But perhaps just to conclude, what I would like to say is that coming from a small country and previous to having joined WHO, for small islands particularly, resilience has been a concept that has been studied very much for 2 to 3 decades, particularly from an economic and environmental perspective. And every study shows that those economies that are more resilient are better governed. So I think the key question ultimately relates to how we are going to better govern our health systems, and particularly how we can ensure that we harness all the resources that are available, including civil society and the private sector. Thank you very much, Matthias. Back to you.
Natasha, thank you so much. I think you really mastered in making resilience a practical and tangible concept in your talk. And I'm very happy that you picked up the health workforce, and that made it actually very clear, you know, what you said earlier, that we cannot move back into our comfort zone, but the time ahead will be also difficult, because if we really want to strengthen the health workforce, we need to talk about working conditions, salaries, and this will be difficult talks. And Erin, in her presentation, she showed what big variations in Europe exist with regards to the health workforce. Also, thank you so much for emphasizing the importance of primary health care in being resilient, and the role of hospitals, and then, of course, the recurrent topic of digital, which is a challenge for many, many countries. But we heard from Isabel that there is some help underway. Thank you so much. I would like to ask you all to switch on your cameras and microphones now. And Erica, please fill us in. What's coming through the chat?
When we're talking about increasing investment in the health system, we also have to think about, the excess capacity that we might end up with. What do we do about that? How do we have surge capacity while also maintaining fiscal sustainability for our health systems? So if we could draw on that, that would be good. Quite a lot of interest in sort of like addressing the health workforce shortages in Europe, which pre-existed. They were in place before the pandemic. So what can we do about that, given how long it takes to train health workers? And drawing on what Natasha says, without causing further shortages, particularly in the global south. And a third question, we've talked a lot about governance, but it would be really interesting to understand more clearly what we actually mean by governance. So is it management of the healthcare system? Is it political leadership? It'd be quite interesting to hear more on that. And there are a couple more questions, but we can hopefully get back for a second round. Thank you
So much, Erica. Let's start in the speaking order with Erin, and you don't need to respond to all the questions, but pick those out which you feel you're best suited to respond to.
Yes, thank you. So I would maybe start with the question on governance, because like governance and like resilience, governance requires a precise definition and something that can kind of be compared on to really define and make sure that we're talking about the same thing, and in that way improving in the right way. So governance is how decisions are made and implemented. So it can be at multiple different levels. It's at the health system level, but it's also how the health system interacts with the other health system functions and systems beyond health. So I will answer that one, and I'll let the other panelists take a stab at the others.
Martin, please.
Yeah, sure, thanks. The thing about efficiency, look, one of the reasons we were in this mess is because people have been going on about efficiency forever. And we've been expecting health systems to run at 95, 99%. And then when there's a crisis, we can't cope. An American writer once talked about the triumph of the bean counters. We count all these things and we actually don't recognize that there will be surges and so on. I mean, this is just madness. So I think we need to move away from this and recognize that part of resilience is having a system that can adapt with flexibility and get away from this, the health system is inefficient. I mean, let's look at all the other sectors in the world, and do we have a defense system? I mean, we're not running our defense sector at 95% activity levels. It's not that we think, well, here we have an aircraft carrier, let's go to war with somebody so we can use it. So I think that there's a bit of double standards here that we need to really tackle. I think the workforce, we have a challenge. But there are things, as Natasha was saying, we need to look at this set of relationships, as we have done in a European Commission expert panel report on task shifting, of how we allocate resources, activities between different types of health workers, so that different individuals with different professional labels, I'm a physician, but there are plenty of people who can, who aren't a physician, who can do the things that I was trained to do. So moving within health workers, and then task shifting between health workers and patients and carers, and then increasingly, as Natasha said, digital technology. So all of those relationships need to be looked at. On governance, health systems are embedded within political systems. And if we do not get the governance of the political systems and the constitutional systems right, then we've got problems. And we've got to be honest about this. The failure of the crisis, the failures in the pandemic in Europe have largely not been about our technical capacity, because we've, here we are, one of the most scientifically advanced parts of the world. They've been about failures of governance at government level. We've had huge levels of corruption. We have had failures of democratic accountability. And this goes back to what is governance? It's transparency, it's accountability, it's participation, it's integrity, it's capacity. And we cannot take the health system out of the broader system, because if you have got widespread failures of governance in the political system, including corruption, which we need to talk about much, much more, then you're going to get failures in the health system too.
We can only hope that some countries seriously rethink their federalism or their relation between center and periphery, and that we get better frameworks to governance than in the future. Isabel, please.
Thank you, Matthias. For the work, the health workforce, the problem is that we already had a shortage before the pandemic. So we have the problems of the long waiting lists before the pandemic, the problem to replace during the holidays, the problems that not enough specialists, different kind of specialists. So we already began with a situation that was not the idea. So that has aggravated. So before the pandemic, we were already talking about the need to increase the health workforce. And we were also talking about flexibility. It's sure that it takes a long time to train the health professionals, but this is also why we were talking about truncality, because maybe when you finish your education, the needs are already different because things have changed. We had the situation in the past with the anesthetist or with the pediatrician or with the gerontologist. So we have already, when doing health planning, suffered from this situation. So, but we have also seen the possibility of adaptation. The example that I put about the health professionals being able to work in ICU was just an example. There were other adaptations. So the system has to be dynamic and flexible. And we cannot plan in very strict frameworks that we cannot move when things happen. So, but there was already a problem. What that doesn't mean with the increase in the capacity and etc., is that we need to establish new beds, a lot of fixed to build a lot of hospitals that we don't know what to do when the situation is over. But there are other possibilities, mobile, structure. I mean, I like the example that Martin has made about the defense system and the army. They don't work with the fixed capacity for everything. They are able to move. And finally, the governance. Yes, this is the health system is included in the whole system of the country. And what we have seen in this pandemic, of course, there were justification. We didn't know where we were at the beginning. We didn't know what we were confronting. But many of the decisions were taken not because of technical reasons, but because of political reasons, and that was for the closure of the borders, the protection, and not allowing medical devices to cross the borders, or some of the decisions that were taken regarding the non-pharmaceutical measures for the citizens. So we need to reinforce how the decisions are taken to establish the, whatever the name, advisory board, or that the specialists are listened, but also we need to take into account that the health system is not isolated, and that some of the health decisions have to be taken in the whole of the society decision, the economic, the social, the education, and etc. But that everything has to be taken into account.
Thank you so much, Isabel. And I take it from you that there is a glimmer of hope. We have witnessed that the health workforce was very flexible and adaptable, and new skills have been adopted during the COVID-19 crisis. And we can only hope that we learn from this and that we are more courageous to deal with the reform backlog we not only have with the health workforce, but also with primary care, public health, digitalization, and many, many other issues. Natasha, please.
Thank you, Matthias. I mean, I agree with everything that has been said, and I think we have to think carefully and critically also when we talk about efficiencies. The point that I would like to bring up is that, of course, we talk about building resilience to be better prepared for the next emergency, but everything is showing very clearly that if we just silo our focus very much towards emergencies and health security, we will lose the plot, because what we need to do is actually build much stronger health systems for peacetime, so to say, drawing again on the defense analogy, to be ready when the emergency comes along. And I think that this is the approach that we are very much working with. And I'm very glad to see that a number of EU countries, for example, are going to use large proportions of their Recovery and Resilience Fund to build better health systems, because clearly this is key to being better prepared for the next health emergency, which will come. Of course it will. But I think that what we hear from most countries at the moment, particularly countries outside the EU, is that their single biggest challenge is a shortage of health workers. Of course, financing is always a challenge, but the single biggest challenge is in fact the shortage of health workers. And I think that when push comes to shove, when we are with our backs against the wall, is when we are most innovative. We have seen this in the pandemic itself, and the pressure is not going to go away. It's actually probably going to intensify in the coming months going forward, with the backlogs that need to be dealt with, and the way in which, of course, people are rightly demanding and expecting the care that they need. And necessity is the mother of invention. So I think that what we will continue to see are actually deep transformations taking place in the coming months. And I think it's very important that we are working hand in hand here with governments on the ground to make sure that the transformations very much go in the right direction. Matthias, I'll stop here because I know we're coming to the top of the hour.
Thank you so much, Natasha. But there's a clear message coming from your contribution that crisis preparedness and response is not good enough, but we really need to invest and strengthen health systems, and we need to strengthen them for regular provision of services with, of course, a safety buffer for whatever will come next. The webinar is unfortunately already coming to an end, but I would like to give Erin the opportunity to have a last 2 or 3 sentences before we close the session. Erin, please.
Thank you, Matthias, and thank you everyone who attended today and presented. I would just encourage you to read the book, which is just a starting point. There are many different lenses to take on resilience, and when we began with the Health System Response Monitor in March 2020, we've kept the experiences from there, but there's always more to learn. And so we'll continue working on this topic going forward. So thank you very much.
Erin, thank you so much. Thank you so much to all the speakers. Thanks, Erica. And bye-bye. Take care.